Tympanoplasty. Tympanoplasty, by definition, it is the surgical repair of the tympanic membrane with or without ossicular reconstruction. And definition, you have to add more also. Yes, some book write with or without tympanic membrane grafting. You have to mention also with or without mastoid operation. So, for keyword phrase, you have to add surgical repair of the tympanic membrane. 1, 2, you have to tell that with or without ossicular reconstruction. 3, you have to tympanic membrane grafting may or may not. 3, there may be most of the time there is tympanic membrane grafting. 4, mastoid operation. If you feel 4 key element, then this is the definition of the tympanoplasty. What is the purpose of tympanoplasty? Purpose is first you have to tell eradicate the infection from the middle ear. That is the great definition. Then restore hearing. Second, you have to know, yes, reconstruction middle ear anatomy may be included, but most of the examiner want to. First, you have to tell eradicate infection. Second, restore hearing. What is the indication? What is the indication of tympanoplasty? You have to come with chronic suppurative otitis media with perforation. Maybe this kind of perforation, central perforation, or there is central perforation. Maybe it's just I give a good figure over here. Okay, sorry. Try to make little good here. Let's say this is assume central perforation. Here the central perforation you can see here. This central perforation. This area is past tensa. This is the flacida area. There is a central perforation over here. You have to do most of the cases we need to do tympanoplasty, and there is some form of tympanoplasty we'll discuss later on. What is the stay important here? We should know it is started early 20th century. Okay, this is the 20th century. Ulstein in 1950, which is you have to know name Ulstein, Wullstein, Ulstein 1950, and Zollner is one of the surgeons. They popularized this kind of tympanoplasty. This able to include ossicular reconstruction. There is a microsurgical technique added later on. Microsurgical means this surgery most of the time performed by the microscope. Most of the time is 100%, and most of the I'm just focus you. There is a use of microscope. Yes, now endoscope came, so I told most of the time, but yes, you have to tell in exam, this is a microsurgical technique. Indication wise, yes, chronic superior otitis media need central perforation more than 12 weeks. You can tell 3 months also, okay, same duration should not be, you cannot confuse here till 3 months or 12 weeks. There is a vesicular damage, so it need it caused the hearing loss. That time need the vesicular reconstruction too. Contraindication of this kind of tympanoplasty, if there is acute infection, AOM, like COM and acute infection, that time you don't able to do the surgery. Other is poor eustachian tube function. Poor eustachian tube function, we can't do the surgery. Unfit anesthesia, and other is active cholesteatoma, that is also contraindicated to do surgery. Yes, this is the commonest question you can get. Maybe 70% of the student, you will get the question from here. What is the type of tympanoplasty? Commonest, they are asking myringoplasty here or type 3 tympanoplasty. Please focus, MBBS, please focus 2 area, type 1, right, type 3, but you have to know either area also. Myringoplasty, please be here. Very important slide here, crucial slide. Only we repair the tympanic membrane perforation here. That is myringoplasty, repair of tympanic membrane perforation. Type 2, we repair the tympanic membrane and we reconstruct the malleus. This is the eroded malleus reconstruction. we do. So this is the type 2 tympanoplasty. Type 3, yes, we repair tympanic membrane. Here you have to know there is a step is intact. Okay. This type, only there one vesicle there. Already malleus is absent, encus is absent, only step is there. Step is full entire. Only one step. This happened in a pigeon. And also we call this one is columella tympanoplasty. They are asking here and there, be confirm and answer in the exam. This is the most common question in your Viva exam. Type 4 is a little difficult. There is no superstructure. Type 5, tympanic repair, and there is a fenestration in the vestibule. Okay. So, surgical approach, there are three approaches you have to know: post-auricular approach or retroauricular approach. Inaural approach, most common is a Lamport. It has a two part. You should mention transcanal approach and endoscopic tympanoplasty. Also there, but here three approach you have no most common: post-auricular, that is while apostrophe whilst other one is endaural. I already mentioned here Lamport. It has two part transcanal approach. Endoscopic tympanoplasty is different phenomena, but you should know. What are the graft material here? Please mention temporal fascia. Temporal must common. First tell must common is temporal fascia. Some student they are saying there is a pericardium or dura mater. These are the yes, but this is not most common. You have to focus the most common. That is the temporal fascia. Next one, pericondium. Here, pericondium may be auricular or tagal cartilage. We can pericondium. We can use. Also, we can use the cartilage. Okay, we can use the cartilage. Please focus on this area answering for the yes. Cartilage tympanoplasty is also now popularized for atelectic ear or retectium. Yellow graph, this is not mentioned in the first answer. Okay, if you examiner asks, you tell more, that time you can tell, but not a first. A step of surgery, you have to remember, first focus on incision, whatever no zone to unknown zone. My focus area, first stage, which is you know. Incision everybody know. So post-auricular or endaural approach, you should know. Then elevation of tympanomeatal flap, just describe tympanomeatal flap. Then there is a perforation here. What we do is perforation press. We can press, okay? We can press. This is the lock here. We can press, remove the some part of the perforation here. So this is the pressing of the margin of perforation. Not. Then we harvest the graft from outside. Then stabilization of flap, there is a more technique, but graft stabilization we can do by gel foam or some other material. Finally, we pack two material or commonly used BIPP pack or neosporin or some antibiotic ointment pack. Okay, neosporin impregnated neosporin impregnated pack. You tell how long we can put this kind of pack, neosporin, at least a week. We can put here in after surgery, BIPP, 3 week. 3 week we can put. So BIPP, some examiner in test to after BIPP, bismuth, ibuprofen, paraffin paste. You have to remember the full form also. Finally, closing and dressing. Mastoid dressing is important. You have to know. Okay, some examiner asks about the mastoid dressing to just know and study this. Post-operative care, yes, keep ear dry for next 4 to 6 weeks. Analgesic, as you need, you have to give an antibiotic. Best avoid nose blowing and trauma. Travel for 6 weeks at least. Complication, sometimes there is a graft failure, hearing loss occur. Maybe there is patient develop tinnitus after a surgery. Sometimes there is infection also. Test disturbance, we see some cases of the after surgery. This occur due to the coda tympani injury. Prognosis, yes, literature show it 80 to 95, 85, 95 for the primary tympanal success rate. Okay, hearing improvement around 70 to 80%. This is definite. I already focused. Size of perforation is a small perforation, large perforation, or stretching tube function. We have to look at chance of infection also. Okay, I try to focus all the exam question in Viva and theory in MBBS in Tympanoplasty.